Hello, this is Dan Wermeling. I am a professor of pharmacy at the University of Kentucky, and the purpose of this presentation is to provide education on opioid overdose and expanding access to the use of the antidote commonly used in medicine called naloxone by its generic name and Narcan by a previous trade name. Part of my role here at the university also allows me to develop medicines, and to do that I formed a private company called Ahartt, and we did develop a naloxone product, a nasal spray, and this was sold to a pharmaceutical company as a unit dose ready to use disposable product. The company no longer owns the product or controls the product. Why are we providing this educational program? Well, first, this antidote naloxone is underutilized in the treatment of overdose, and we need healthcare professionals to obtain additional education because they care for individuals and families who have high overdose risk patients, and we hope to reduce deaths and the consequences of overdose by learning how to prescribe, dispense, and administer naloxone. These are the 5 objectives. We're going to first provide an overview of the epidemiology nationally in Kentucky and to show you how to look at overdose in your local community. We're going to review the pharmacology of naloxone and the information on the approved drug products. We'll talk about the different ways that naloxone can be given. There are some legal requirements for prescribers and dispensers of naloxone for opioid overdose prevention, and we'll discuss counseling that's necessary for the patient and for the family when we fulfill naloxone prescriptions. Now, nationally, the last few years, we've had approximately 16,500 deaths reported per year, and that seems to have stabilized lately. Initially, the majority of deaths, let's say 5 years ago, 3/4 of them might be associated with prescription medicines and 25% associated with heroin. Now, with restrictions on prescribing of opioids, the total number is about the same, but there's been quite a shift so that now it's roughly 50-50 deaths from prescription opioids versus heroin. In Kentucky, we've stabilized between 1,000 and 1,100 deaths per year, again related to changes in prescribing practices for opioids in the state. This may well be an underestimate because this is what's reported through various channels and may not include all coroner cases, so the total death count is likely higher. The medicines most commonly associated with an overdose death are oxycodone or hydrocodone, which are in common prescription medicines, fentanyl, which is in prescription medicines and also is being used clandestinely by manufacturing fentanyl outside of normal pharmaceutical production, and heroin, which you would mostly see in toxicology reports as morphine. Many overdoses involved co-intoxication, and that means they've taken more than one product either because of prescription or outside of illicit use, and it's common that benzodiazepines such as Xanax or Valium or Ativan would be also in the decedent's body. And we would also find that drinking alcoholic beverages was also common, as well as perhaps other prescribed medicines that have a central acting property to depress the central nervous system. The decedents are typically middle-aged males, and injecting medicine is one of the highest risk activities that a person can undertake, and so this provides extremely high blood levels in a very short period of time. Mixing of drugs, of course, creates a dangerous combination, and whether that's done by prescription or illicitly. Patients who are prescribed opioids have a higher risk as the dose of morphine or its equivalent in another product are increased, and the risk of an adverse event or a death is greatly different when patients take 100 milligrams or more per day or the equivalent. The risk increases when we have frail pain patients who may also have other comorbidities such as COPD, renal function, heart disease, etc. And then unfortunately, for those who either have gone through supervised detoxification or have been in prison or jail, have lost tolerance because they have not been receiving an opioid for some time. And so if they were to go back to using doses of opioids prior to their incarceration, then that will likely be an overdose compared to what they were accustomed to consuming prior. Another common theme is a comorbid mental illness. And you will see commonly that there is a high rate of depression and bipolar disorder with individuals who have passed away. And in fact, suicide by use of medicines is not uncommon. And based on coroner and medical reports, it's estimated that 5 to 10% of deaths involving opioids are intentional. In terms of the national picture, we can look at the age-adjusted death rates in the top image of the map of the United States, and the darker colors are those states associated with high rates of death. And so you can see in our region of the country, in Appalachia, that is a common problem. The bottom graph demonstrates that there's a high correlation between the sales of opioids, prescription opioids, and the rate of death. You'll see that dark-colored states in the bottom map have significant overlap with those in the top graph. Now, getting closer to home, in Kentucky, the highest rates of mortality are associated in our rural counties. And you can imagine that if the rate of overdose mortality is 8 per 100,000 in the United States, and you look at these particular counties as an example, you can see that this explains the devastation that occurs in our rural counties from drug overdose. So you can see somewhere between 55 and 75 deaths per 100,000. It's likely that almost every resident in each of these counties would know at least one person or a family who likely had a death in the family from overdose. The highest total counts by number are in more of our larger population centers. So Jefferson County, which is Louisville, in 2014 had 184 deaths. Fayette County and Lexington, 84. Northern Kentucky, the three counties at the top northern counties of our state, Kenton, Campbell, and Boone, you can see constitute something that approximates Jefferson County alone. And then we get into more of the rural counties again, where we see the devastation again that occurs as a result of overdoses in smaller communities. Another way to look at this is the hospitalizations that actually occur. And so the first chart here of the state of Kentucky with its counties show that eastern Kentucky has the highest hospitalization rates in our state. And so this has a significant cost to us. In this case, it's estimated to be about $150 million has been processed as charges through our hospital system. Now, if you estimate that perhaps 5% of hospitalizations through the emergency department actually involve the only 5% of the total population, then the ambulance services must be tremendously busy in recovering people and bringing them to the hospital. So this is for prescriptions. Now, if we take the same idea and apply it to heroin, you can see that the larger population centers in northern Kentucky, Jefferson County, Louisville, and in central Kentucky, Fayette, tend to have the highest localization of heroin overdose hospitalizations. You can see that it likely follows the interstate system from I-75 south in Cincinnati and I-65 south from Indianapolis to Louisville. So with all of this devastation that's occurring and challenges to the health and vitality of our society, there have been a lot of reactions that have occurred to how to think about the overdose epidemic and what to do. We have lots of new laws and regulations occurring at all levels of government. We have professional licensing boards looking at professional practice standards, as well as professional societies creating best practices and guidelines for professions who are involved with opioids in one way or another. So we hope then that we won't need to get into the professional jeopardy issues with criminal prosecution, boards, administrative action, and malpractice with professionals involved with opioids if we can do a better job. So we'll talk about one function now that's come through federal and state programs, and that is to evolve into a new strategy of using the antidote more widely. And as I said, the antidote is naloxone, and we're going to discuss then the use of it outside of its standard locations, which would be typically post-operative recovery rooms, emergency rooms, and ambulances. So this is a harm reduction strategy, and it's really focused on individuals, but in particular families, for individuals who are at risk for overdose. And it's not uncommon that if there's one person at risk, that a second one may also be in the family. Now, the antidote itself, naloxone, has been on the market and FDA approved since 1971. And really functionally, the only clinical use of it is as the opioid antidote. So when someone is relatively or significantly impaired by an opioid, then naloxone can be used to wake them up. Now, in this family utilization, this is more of an outpatient program than something you would see, again, in a hospital or an organized healthcare setting. So it's an interesting model where we're training an addict, a dependent person, or a pain patient, and the close family contacts to save another person. And in fact, you need the family to save the patient because the patient cannot save themselves. Typically, an individual who is overdosed is unconscious and therefore is unable to administer the remedy to themselves. Now, this brings up an interesting legal question. It's similar to the question or issues posed by EpiPens, because it's common that an individual overcome for a bee sting or peanut allergy or asthma may not be able to save themselves either. And so in this case, we prescribe to a person, typically, that's a patient-physician relationship, but they can't help themselves. And so we need to authorize a layperson to administer the drug to another person. You could think of this in the context of Good Samaritan issues. Now, we have precedents for this in state law. for boards of medicine and pharmacy where there are precedents for prescribing and dispensing epinephrine and glucagon, where a third party is necessary to rescue the patient in an emergency situation. Now, naloxone itself, pharmacologically, has really only one function. And regardless of whether someone took heroin, labeled as H, methadone or morphine as M, and other opioids labeled as O, or OxyContin, however you wish to look at it. But these medicines, when they are hitting a receptor in the brain, provides pain relief, can provide pleasure and reward, and the downward problem is that it causes central nervous system and respiratory depression. Now, what the antidote will do, naloxone, labeled N, is as one of these medicines is sitting on the receptor and comes off the receptor, naloxone can take its place in the receptor. So it's a competitive antagonist and is then able to reverse the respiratory depression, the central nervous system depression. If someone has been dependent on opioids, it will cause opioid withdrawal symptoms, and we'll talk about that further in this presentation. So who might be eligible in a household to receive naloxone? And we use another term called co-prescribing, so that if they were provided opioids through prescriptions by physicians, then you could consider co-prescribing naloxone if there is an at-risk circumstance. So here's a whole list of them, 13, 14 types of patients, and they fall into certain kinds of categories. If you've already been hospitalized where you had emergency treatment, you're at risk again. If you use opioids illicitly for non-medical purposes, if doses are high, if methadone is being used because it's very complicated medicine, if you have an opioid prescription and certain other medical conditions such as significant history of smoking, COPD, respiratory illnesses, renal and hepatic dysfunction, since if these organs are not functioning properly, then you can't eliminate the toxin. And then if you take other substances, either prescription or alcohol, that are also central nervous system depressants. And then if you've been abstinent or detoxed for other reasons, then you may be at greater risk if you went back to using doses of an opioid, as you may have done in the past. And in Kentucky, a very relevant topic is if you have trouble accessing emergency medical services. So we have a number of communities where these are quite readily available in northern Kentucky, Louisville, Lexington, and other mid-sized cities. But we also have a significant rural population, and getting emergency medical services in a time-dependent fashion can be challenging, and so time is of the essence. And so you could have a prescription of naloxone at home to save time for recovery. Now, naloxone has a half-life, meaning how much of the drug is still left in the bloodstream, of about an hour, depending upon which route of administration was used. And so the duration of action for recovery is about an hour. So if you had naloxone at home for someone at risk, you have bought this person who's overdosed an hour until emergency medical services arrive. And so it's imperative, you must call 911 because this person is still critically ill. Now, we may even need further doses of naloxone, either there at the accident site or in healthcare when you go through the ambulance or into the emergency room, because analgesics last hours and sometimes even a day. And so the duration of Vicodin and immediate release products tend to be about 2 to 6 hours if you took standard doses. Extended release long-acting products can last 8 to 24 hours or longer. And if you swallowed a number of pills of these things, the overdose can even be prolonged because the pills tend to agglomerate together and form a concretion and will be releasing drug for some period of time. So individuals may need repeat doses, or even if they reach the hospital, an infusion of naloxone for hours up to a day, since the opioid lasts longer in the body than the antidote. So I repeat, you must call 911 so that care can be continued. Now here's an image of new products, some old, some new, of naloxone. And so we're going to discuss the various routes of administration. The initial delivery isn't going to be promoted for use in outpatient settings because it's a route called intravenous administration. But the other routes you'll see here are using intramuscular injection and nasal spraying. And so we're going to discuss these products in greater detail. Now, this table gives you some sense of the dose and the route of administration, the onset and the duration of products that we have available. Intramuscular is one of the older versions, if you will, of the medicine. You can use a syringe and a needle to give a muscular injection. The initial dose is 0.4 milligrams, and it will start to work in a matter of minutes. And it'll last about an hour to an hour and a half. Subcutaneous, which is also similar, kind of think of an insulin shot, same dose, same onset, and about the same duration. Now, our ambulance services and paramedics have been using an intranasal route of the injection. The dose is 2 milligrams, which is 1 milligram per nostril. It starts anywhere from a few minutes up to 8 to 10 minutes or so, and can last for an hour or two. The paramedics perform this function because we'll talk about the side effects, and one of them is that sometimes recovery can have agitation, and having needles around can sometimes be a hazard for paramedics. And then the next product is intranasal Narcan, which is a recently approved drug from the FDA and has a 4 milligram dose in a single spray, onset again in a few minutes and up to 2 hours. And one last product that I'll talk about also in the presentation is intramuscular kit that is an auto injector, and I'll explain more about that when you can see the picture. That is another version of intramuscular called Evzio. So initially, ambulances and harm reduction programs would use a vial of naloxone, which has the 0.4 milligram dose in it, and they would draw this up as a standard injection with a needle and a syringe. And in step 3, you can see the dose being administered to the top of the thighs or to the upper shoulder area. And so this would be a standard intramuscular injection, and something that perhaps a paramedic would do if that was the route chosen, if intravenous administration wasn't available yet. The off-label use of naloxone injection via a sprayer is also another option. This is what I described as what paramedics started to do. And so this is a pre-filled syringe which has naloxone solution in it. You remove the caps from the syringe holder, and the cartridge of naloxone then goes inside. You can see that here, goes inside and is twisted in place. And then a separate product that can be purchased is a nasal spray atomizer called the mucosal atomization device, or a MAD 300. And you would attach that to the front of the barrel instead of a needle. And so what you've done is converted an injection into a nasal sprayer. And you can see that demonstrated here, where the syringe is then oriented by placing it fully into the nostril until it can no longer go further. You press the cartridge down and the nasal spray then comes out into the nasal cavity. So this is off-label, and what I mean by that is that this Narcan naloxone injection here is approved by the FDA for typical injection administration. And this device here, the mucosal atomization device, is an approved FDA device. What is not approved is combining them together to do this. So a physician can order this without any problems within their scope to order that a person receive a kit that uses this type of application. A ready-to-use version of nasal delivery is called Narcan nasal spray. And this is a product that is self-contained and ready to use. And the way that you use it is that the tip of the nasal sprayer is placed fully into the nostril until it can proceed no further. And then you push the plunger with your thumb and it will move in this direction. When you do that, when you put enough force on this plunger, it will cause activation and the spray plume will come out inside the person's nostril. This product was just recently FDA approved in November and should be available to purchase in pharmacies beginning March of 2016. So this is FDA approved as designed. And I also need to mention this auto-injector called Evzio. This is an intramuscular injection. And what's interesting and fascinating about this device is that it talks to you. And so it has a computer system inside that understands exactly where you are with handling it. And so when you open it, it talks to you about how to place the auto-injector into the correct location on in this case on a patient's thigh. When it perceives it's in the proper orientation, it'll ask you to push down, and it administers the medicine over the course of 5 seconds. Okay, so you take the tab off, put it here, it'll talk to you, you push it down, it activates, it takes 5 seconds to provide the injection, and then you can remove this. There's also a repeat dose in case a second dose is needed. So this is another option that's available. So we have these 4 options. Old intramuscular, new intramuscular, old nasal spray, new nasal spray. Now the harm reduction community has gone farther to create what are called Narcan or naloxone kits. And the program generally is that there's a training of individuals, either the patient and or their family or close contacts, on how to respond to an opioid overdose. And so you can see the instruction kit there to the right. They also provide into the kit a face shield for conducting rescue breathing, meaning you're breathing for them, some gloves, the Narcan, and the nasal spray adapters. So this mirrors what an ambulance would have in stock, except now that you would have this in a little package and you would have this at your home. And so we're going to talk about this particular practice more because this is moving naloxone out of the organized healthcare systems of recovery rooms, operating rooms, emergency rooms, and ambulances. So you would have this kit then to be able to take home. Now in Kentucky, we have laws that enable this, and part of the element of the law is that for pharmacists, and probably recommended for others, is that we should provide both verbal and written education to the patients and families who are to receive these kits. So these are the 6 elements that could be recommended. One is, what are the risk factors for overdose, and how do we prevent overdose in the first place? However, if you think there's an overdose, what does the overdose actually look like? What would a patient or a victim of an overdose actually appear? How would they appear to you? What do you need to do in terms of steps? Information about the antidote itself, as we've discussed. How to administer naloxone. And then for the product in the kit that you're given, how do you properly store it? And what's the expiration date of the product that has been received? So we're going to go through some of these steps. Now, an overdose is something where patients generally are not responsive. And the way that we do this is that we yell and scream and get their name and yell their name and try to get them to respond. We can also do something as a sternal rub, meaning we're taking our fist and rubbing it on their sternum or on their scalp, which might cause a little bit of pain and hopefully would stir them. So if they're not responding to voice and contact, then this is a sign that could be leading us to an overdose. If you looked at their breathing, they won't be breathing very frequently, and it won't be a very deep breath. So it's infrequent, shallow respirations, and at worst case, they may actually not be breathing at all. If they're not breathing, then their skin will be dusky, blue, gray, cyanotic, and you will see this on the skin and particularly lips and fingernails. Other kinds of things common to observe would be that their blood pressure is low, hypotension, and that their heart rate is slowed. If they have been in these conditions for some period of time, which could be hours, patients will proceed to coma, and if they haven't been breathing adequately, then they may suffer death as a result of secondary cardiovascular collapse. So this is what we would see as kind of a picture of what a person would look like. So what do we do? What is the response? And so as I mentioned, we try stimulation first, because stimulation can first help us check for a response, but also stimulation causes people to breathe. And so don't worry about annoying them if you do this. Stimulating them will make them breathe, and if they're trying to talk to you, then they will breathe also. So stimulating them is good. We want to call 911 because we know that even in the best of circumstances, a 5 to 10 minute ambulance response time might be in order, and if they're busy or in a rural setting, it could easily take 20, 30 minutes to an hour, depending on your circumstances and where you live. But you've got to get the ambulance rolling. Then you would want to give the naloxone. So if you have the intramuscular kit or the nasal kit, either way, administer it. Then if the person's not breathing, you have to breathe for them. In fact, breathing for them is more important even than the antidote. So oxygen is what they don't have, and you have to give that to them by breathing for them. If they are breathing, then put them in the recovery position, which you see demonstrated here. They're on their side. This top leg is propped over. The arm is propped under the head. And this other arm is holding up the head. And the reason we do this called the recovery position is that if a person vomits, the vomit would come out the side, and we can still clean that out. But if they're laying face up, then there's a risk that they would inhale the vomit, and that could cause them to have serious consequences. And then, of course, we stay with the patient until help arrives. Now, if a person is responding to naloxone, they will start to regain consciousness slowly, but they won't be in a position to necessarily engage in a conversation with you meaningfully. They're going to be really groggy. They may be agitated or angry. They could be nauseated or throw up. So these are the things that can occur, and we'll cover that a little bit further. Now, there are some contraindications, which are few. Really, it's only if there's a known hypersensitivity or allergy to naloxone, which is a very uncommon circumstance. Another risk circumstance is if the reversal is incomplete. And this happens in one of a couple of circumstances. One is if they take a medicine called buprenorphine, which is a partial agonist or a mixed agonist-antagonist. And reversal takes much longer than, say, morphine or fentanyl or oxycodone, etc. And that's because the drug buprenorphine has a very high binding affinity for the receptor in the brain. It's hard to get it off the receptor, so it takes much longer for naloxone to work. Whereas fentanyl may need more naloxone, not because of this receptor binding issue, but because fentanyl is so potent, and that it's likely that a fentanyl overdose is a massive overdose, not one associated with doses used clinically in medicine. And so this may also be difficult to reverse, or you may have a partial reversal. Another reason for partial reversals is that they may have taken other substances and overdosed on those as well. And naloxone will not reverse benzodiazepines like Xanax or alcohol. Something that can happen is that giving naloxone can precipitate withdrawal, and we'll talk about that in just a few minutes. And remember that the effect of naloxone is limited in duration. And so you've bought this person an hour. They need EMS care as soon as possible. So please, please call 911. Now, what happens in terms of the safety and tolerability of naloxone when somebody receives it? So depending on how long a person was dependent on an opioid, so the reactions can be quite different from someone who had an accidental overdose and isn't accustomed to taking opioids to a person who is a regular user of opioids and now receives the antidote. So there can be mild to more severe opioid withdrawal effects. A simple way to think about it is the worst flu you've ever had. And so they'll have body aches, they'll be breathing rapidly, they'll be sweating, they'll have secretions perhaps coming from their nose, they may be tearing, yawning, and they may be irritable, agitated, and in fact could be combative, and wish to leave the scene of where the overdose actually took place. GI effects, gastrointestinal effects are also common: nausea, vomiting, and diarrhea, abdominal cramps. And as I mentioned, we have to be very careful with the risk of vomiting and that they would aspirate stomach contents. And so the rescue position is a must. And then in some patients, there can be serious consequences of autonomic instability, and these are manifested as high blood pressure, fast heart rate, arrhythmias, which are abnormal heart rhythms, and up to cardiac arrest, pulmonary edema, seizures, and death. So waking up someone can have some serious consequences. This is why EMS and 911 are so important. In terms of special populations, there's always questions about whether to use this drug in pregnancy and or someone who's breastfeeding. So depending on the product, you'll see it as a category B or C, which generally means that we don't have a lot of information that shows that there's any teratogenic or toxic potential in animal models, and so it doesn't tend to cause birth defects. However, it can cause fetal distress. So there is a risk that if a woman is pregnant and overdoses and receives naloxone, that it could cause uterine contractions and also fetal distress in opioid-dependent mothers. The organizations that are involved with creating guidelines recommend that pregnant individuals at risk still receive a naloxone kit because of the immediacy of the circumstances with the risk to the mother. Relative to older people, they're going to generally have higher systemic blood levels of opioids, and so they might need also different doses of naloxone, but we just don't have sufficient information to really understand the issues in geriatrics. Now, it's important that if you have a kit that you treat it well at home. So naloxone breaks down if exposed to light and to higher temperature. So you can see that the kit here would protect it from light, and so here you can see the vials are clear, and so if left in the sunlight, the sun will degrade the naloxone in the vial. Also, higher temperatures can cause the drug to degrade, and so at the time you might need it, it may not be as effective as if fully potent. You should also look at the expiration dating, which would be on the label of every vial. In general, naloxone sold would still have approximately 12 to 18 months of stability. After it's expired, you should consider having a replacement of medicine put back into the kit. The auto-injector has its own instructions as well for storage and care, and you would just follow the instructions and keep the auto-injector stored in its outer case as it is supplied by the manufacturer. So now that we've had all these products, of course everyone's always curious, what does it cost? And so here are the average wholesale price to the University of Kentucky, through also looking at Lexicomp, which is our online resource where we can look up costs along with other drug information. And so the general price of the injection vial, the old way of doing intramuscular, is $18.71. That's the acquisition wholesale price for the pharmacy, not a retail price. And so putting a kit together might still involve something like a $30 to $40 price per kit. The Evzio product is the new version of intramuscular, and the acquisition price from this source is $345 per unit. So you can imagine that the price of a retail pharmacy transaction would be higher. The off-label naloxone product, naloxone injection at the higher strength, is $39.60 per syringe. If you put 2 syringes in a kit as recommended, along with 1 or 2 of these, you could see that a off-label kit would easily cost somewhere between $70 and $100. And then the newly approved product, Narcan nasal spray, has different kinds of pricing. The average wholesale price for a 2-pack kit is $125. The retail price would obviously be higher than that. Public interests such as government agencies, public health organizations, firefighters can get a discounted price of $75 per 2-pack. So then, is giving naloxone out this way considered to be cost effective? And so these are some of the factors that would affect a conclusion. First, we know that this is a relatively younger population that's treated. So the life years saved from a life-saving medication would be a significant number. We also know from reports from the federal government that there are thousands of reversals reported. And the amount of reversals depends on the degree in which any particular state has adopted these practices. So this is well established in Massachusetts and some other states, and others are coming online. Dr. Alex Wally from Boston has conducted research in Massachusetts counties where they can show that there is a harm reduction of decreased mortality for counties who have harm reduction services, including naloxone access, as compared to neighboring counties that do not have this service. Further, Dr. Coffin from San Francisco, Philip Coffin, has an article that directly addresses a model for the cost effectiveness. And the metric is frequently the dollars per life year saved. And so because the drug is relatively inexpensive as medicine goes, and that we have a lot of life years saved for any given person, you can imagine that the cost per life year saved is small. And in fact, that's what he demonstrated. It's in the $15 to $25 per life year saved. Where a lot of other drugs that we use that are expensive, such as chemotherapy, for example, are considered to be cost effective in the $30,000 to $50,000 per life year saved. And so you can see that naloxone comes nowhere near that. So this is highly cost effective. Further, some patients who have gone through this near-death experience and recovery and revival from an overdose become motivated to seek treatment. This is a critical factor in recovering individuals afterwards. So survivors, and some of them, are beginning to enter substance use disorder treatment. And so this is obviously a key time to try and prevent a future overdose for anybody who has been a survivor. So now prescribers, doctors with these 4 products need to think about which ones they would select and what the prescribing considerations might be. This would be akin to healthcare systems such as a hospital or a pharmacy benefits management program or an insurance program, where they're going to look at these products and think about which ones they might have on their formulary for a variety of reasons, and also to understand the differences of them through a variety of different factors, some of which I've put here on this slide. So one of the key differences across the products is that you notice that the doses are different, and in fact the blood levels are different amongst the products. And so the need for repeat doses, or perhaps the intensity of withdrawal, may be different because the blood level exposures are different across the products. And the blood level peaks differ from approximately 4 to 8 times from bottom to top. So the maximum concentrations achieved in the first 20 to 30 minutes can be quite different. Then you would have patient factors. And so based on age, infirmity, dexterity, coordination, vision, a variety of patient factors then should also be considered, because these products have different capabilities and potential limitations. And so again, this requires individualization of choosing the right product for the right patient. There may also be patient preferences. And so if there is not a preference from the physician, then of course consulting the patient would be important. And so they have choices then for using a needle for intramuscular with one of the other 2 products, or using needle-free. And there's one potential benefit of needle-free, and that is you would have less generation of biohazardous waste and the potential for needle stick injuries. Also, prescribers and governments and insurers would also look at the FDA approval status and its indication. So the 3 of the products, with the exception of using the off-label naloxone solution injection with the mucosal atomization device, the other 3 products are FDA approved as they exist and as they're labeled. The other 2 products can be used, but they do not carry the same indication as the 3 approved. Also, states may have laws for the products that can be released through the harm reduction programs. And you would need to consult your Board of Pharmacy or state regulation as to if there are any limitations on which products are authorized for this purpose. And then, of course, you may choose the best product for the patient, but if they can't purchase it or buy it or afford it, then it's not the best product because they can't access it. And so the cost and reimbursement matters are still evolving around the country. And so you would need to contact your pharmacist who dispenses your medicines so that they can link your insurance programs with the product options to see which ones are approvable and reimbursable by your insurance. One of the reasons for this presentation is to discuss ways in which greater access to naloxone can take place. Now, one way to think about this is to work backwards from a pharmacy and a patient interaction back to the prescriber and the person's identifying an at-risk household. And you can think about all the steps that are necessary as a standard of care, just as we would with any other prescription medicine. So you can develop protocols and standards of cares in all the different venues by which a patient and or their family become aware to you. It could be that they're seeing you as an individual prescriber. They could be in a pain or substance abuse treatment program. They could be seen through a public health clinic, emergency medical system, ERs, hospitals, etc. It could be that the school itself is sponsoring programs and wishes to have naloxone available to the family contacts. And an evolving practice, I hope, that does become more prevalent is to do two things, and that is to take naloxone out of the pharmacy and make it mobile, either in an actual mobile vehicle. So here in Kentucky we have a mobile pharmacy, or for a pharmacist to take the kits out. And what I mean by that is that you process prescriptions as you would following federal and state law, except that you can do this outside of the pharmacy. And I hope these are all avenues by which you may be practicing, and that you can work with your colleagues in your environment to figure out ways of how you could address this for your patients. Liability is also an important question, and many states now have laws and regulations that describe the practices permitted in the state. And there are those, and in Kentucky we have them for prescribers and dispensers and for Good Samaritans. So, as we mentioned earlier, as typical, there are criminal, civil, and administrative liabilities, and so we need to make sure we're following our laws and regulations for handling a prescription medicine. There are also Good Samaritan provisions in the Kentucky state law for a layperson to possess and administer this medicine, and to allow third-party prescribing, meaning that instead of for the patient, you prescribe it for the parent, sibling, spouse, etc., for them to have in case of emergency. And also for calling 911, and that you should call 911, and if there are illicit substances and drug paraphernalia there, that our law provides that you would be immune from prosecution if you call 911 to treat an overdose. This map of the United States shows that most of the states, as of February, have some form of naloxone and or Good Samaritan laws for opioid overdose. And so my sense is that this will continue, and we will likely have most, if not all, states in the next few years having such laws. Now, when we're thinking in healthcare delivery, and in particularly for what the pharmacist has to manage, or anyone, as let's say, as a physician who wishes to prescribe and dispense, we have to review and understand all of our medicine, pharmacy, nursing acts, and what is permitted relative to prescribing, dispensing, counseling, who can do financial transactions, who can give drugs, what the liability issues are, and then what laws we have for the various parties who participate in naloxone. And so these are all things then that you would have to think about in your role in the profession. Pharmacists in Kentucky have been provided the ability to work under a physician's protocol by signing a collaborative care agreement and completing certain continuing education requirements. And so a doctor is providing a standing order and a contract to a pharmacist as the healthcare provider, and so that we can then initiate dispensing of naloxone independently of a prescription received by a physician. So we have collaborative care agreements, and a number of states now have this, where they've expanded an ability of a pharmacist to assess patients, and it's not really prescribing per se. We are using the standing order and protocol to dispense naloxone. So these protocols are developed by the relevant boards of pharmacy and medicine. The pharmacist completes continuing education program and has a collaborative care protocol jointly signed off and submitted to the boards. And there's lots of ways that pharmacists can participate in this, at finding at-risk families and patients through the prescriptions that we receive, looking at medication histories, and through our Casper system. And in some cases, patients or families may come directly to the pharmacy seeking access to this, even if they didn't have a prescription for an opioid to present, or that they may not have a physician. So in conclusion, there are a lot of interprofessional opportunities to identify at-risk individuals and families, and to have all of the elements of our healthcare system playing a role in organizing systems that provide safe and effective access to naloxone for at-home use. And as part of that, this program and others hopefully will continue educating and training for practice collaboration, that there will be increased public awareness, much as we did for automated electric defibrillators, and that this is part of a patient, but in particularly family counseling, and hopefully a reason to begin a discussion on seeking treatment. So in the end, I hope that we can create these interprofessional systems and can adopt these things within your community. Identify patients at high risk, either through pain management systems, substance abuse programs, and other venues. We have to educate patients and families, prescribe and dispense, and counsel. I use these various resources, which you can find on the internet, which would have more expanded information on any of these topics. And thank you for participating in this educational program. Please feel free to write me an email at dwermel@uky.edu, or you can call me at area code 859-323-7499. Again, that's 859-323-7499 should you have any questions. Thank you.